I'm Richard Kloos. I'm the Secretary and Chief Operating Officer of the American Thyroid Association. Hopefully I said hello to many of you yesterday. And I again want to take this chance to welcome you here to the American Thyroid Association meeting. And I want to specifically point out my thanks to this our program committee and our course leaders for today for putting this together for you. My sense is a strong desire to tell you how important you are to our future. The American Thyroid Association knows that our future is in our youth, our trainees, and it's a strong priority for us to make you feel welcome, to make a high-quality educational opportunity. You've got two outstanding teachers here today, and we hope that this is if not your first, one of your early good memories of coming to our meeting. We hope it's one that you'll come to year after year, tell your colleagues, and see our society grow and benefit you. So if you can help us come up with ways to make this more meaningful to you, please share those. Please check out our website. We spent a lot of time developing what we think are tools that would be meaningful. So without further ado, I'll hand this over to Andrew and Stephanie, and I thank you.
So as Stephanie outlined, in a little bit, in a few words, the whole program for the few days that we're here. For this morning specifically, I'm going to go over the basics of thyroid ultrasonography. Stephanie is going to follow up with a more advanced set of slides on thyroid ultrasound and FNA, including lymph nodes and parathyroid glands. And then we're going to have a little bit a lecture by one of our cytologists, and we're going to have the practicum. So just for a show of hands, how many of you have ultrasounds that the fellows use in your program? Okay, pretty much everybody. How many don't? Maybe that's the easier. Okay. And then of those of you that have ultrasound, mostly peds. And of those of you that have ultrasounds and the fellows use them, I assume the majority also do the FNA guided ultrasounds of nodules. How many of you are in your program do you biopsy lymph nodes, ultrasound guided biopsy of lymph nodes? So fewer. Okay, so thanks for that show of hands, and I'll get started. So, as most of you know, a thyroid ultrasound uses high-frequency sound waves to take a picture of the thyroid gland. As seen in this pictorial, the sound waves that are used are anywhere from 7 to 15 megahertz. The higher the megahertz, the less penetration, but the better the images. The lower the megahertz, the more penetration you get, but the more grainier the images are. So when you're doing thyroid ultrasounds, and depending on whether the lesion is superficial or deep, you should be adjusting the megahertz on your ultrasound. And in some cases, it's usually tiered to around 8, around 10 to 12, and around 14 to 15, or you may get a designation that that's Gen for general, which is around 10 to 12, Pen for penetration, which is 7 to 8, and high resolution, which is 14 to 15. So, as you all know, the patient lies in the supine position. Hyperextension and positioning of the neck is very important. Ultrasound gel is applied to help with the transmission of these sound waves. The resolution we discussed, and of course the neck is visualized in both the transverse and the longitudinal planes. In terms of anatomy, the lobes are oval-shaped with a rounded superior pole and elongated inferior pole. The lobe dimensions are as you see there. It's variable, but on the order of 4 to 6 in length and approximately 2 centimeters in thickness. And you'll hear thyroidologists or your supervisors, mentors in your clinics refer to 10 to 15, 10 to 20 cc's as the volume of a normal thyroid gland. In terms of looking at this a little bit more anatomically and trying to mirror an anatomic cartoon with what we see on ultrasound. We, of course, see the trachea, which is centered here. The esophagus is usually positioned as shown here, rather than right behind the trachea as shown in the cartoon. The thyroid overlies the trachea with your isthmus in the middle, carotid and jugular as shown here to the left and right, and surrounded by sternocleidomastoid muscles and other neck strap muscles, which can usually be easily differentiated from the thyroid, although if you have a hypoechoic thyroid gland, it can be difficult, and it can be difficult, as you'll see in the advanced section of this presentation. It can be difficult to distinguish muscles from lymph nodes in the neck once the thyroid has been removed, and we're doing follow-up ultrasonography for patients with locally metastatic thyroid cancer. In the longitudinal plane, you see the thyroid as pictured here with the lower and upper poles, and as you move more medially, you'll see tracheal cartilage. As you move laterally, scanning the neck, you'll see your carotid and your IJ as shown in the pictograph on the right. So essentially, and we'll go over this when we're doing the practicum, you're scanning the neck in a transverse way, much like a CT scanner, hopefully trying most of the time to remain perpendicular so you can easily you can visualize the anatomy and know what you're seeing, and then in a similar way doing your transverse sections going from midline all the way out to the blood vessels, back to the trachea, and same thing on the other side. So now what about the use of thyroid ultrasound in the diagnosis of thyroid nodules? Thyroid nodules are common, and they increase with age just by palpation, but since we've begun using ultrasound from the early to mid-90s and now in this after the year 2000, we've been discovering many, many more nodules that were previously clinically not detected. And the majority of these lesions, the prevalence of thyroid nodules, tends to occur more commonly in women, and they increase as we age. So if you look at every age group, here we have women and men 20 to 30. There's a twofold increase in prevalence of thyroid nodules in women compared to men, and that holds true as we age, with 40 to 50-year-old women having almost a threefold increase compared to the younger women, and we continue to have this increase in prevalence in females compared to males. So what are we missing? Well, part of this, what we're missing, is in multinodular glands. So one may palpate this large left-sided thyroid nodule, but miss this smaller right-sided, deeper thyroid nodule. Similarly, given the depth and the size of the sternocleidomastoid and strap muscles here and the depth of this nodule, one may miss this relatively large 1.5 solitary nodule because of the depth and the overlying strap muscles. And there's also issues that have to do with consistency of the surrounding tissues and thyroid, normal thyroid, compared to the density or firmness of the nodule. The more similar, the less likely you'll palpate the nodule as being different from the surrounding tissues and normal thyroid. The more different they are in consistency, the more likely you are to palpate something that's even deep. So depth and consistency of the nodule are important. And sometimes we feel nodules that may not be there. So this is an example of a hash gland with what we call pseudonodules, where you could see that you may be palpating what you feel is a nodule here, but really it's an irregularity and heterogeneity within a hash gland. So looking at what we're missing a little bit more systematically, it's not surprising that we would miss the vast majority of less than 1 centimeter thyroid nodules. it's a little surprising that we would be missing 50% or close to 50% of these relatively larger and palpable to the most of us thyroid nodules that are 1 to 3 centimeters or larger. However, many of these are missed in the context of a multinodular goiter, where one nodule is palpated, but we miss the 2 or 3 other smaller ones that are less easily palpable. Nonetheless, and for these reasons actually, both the ATA and the combined recommendations of ACE and the South American and European thyroid associations with their guidelines listed here, the ATA 2009, ACE, ETA, and AME from 2010, both highly recommend the use of thyroid ultrasonography in essentially all patients who are suspected of having thyroid nodules. Now, what are the characteristics of thyroid nodules that we use or pay attention to? So there's echogenicity, hypoechogenic, isoechogenic, hyperechogenic, and we'll discuss a little further so iso or hypoechogenic are more likely to be benign. Hypoechoic, the hypoechogenicity tends to carry a greater risk of malignancy, although, as we'll see, benign nodules can be hypoechoic. Benign nodules can have calcifications, and we'll discuss on the next slide the different types of calcifications that one can see and their significance. The presence or absence of a halo and how the margins look, irregular and lobulated versus smooth. And vascularity, and how that vascularity is distributed, peripheral versus central, when we talk about thyroid nodules, but also about when we discuss lymph nodes, which Stephanie will discuss in the follow-up talk. So calcifications, what kind of calcifications do we have? Eggshell calcification, which is what it says, a calcification that's peripheral and surrounds the whole nodule. It's unclear. The significance of eggshell calcification is unclear. There's insufficient evidence to claim it to be a benign versus suspicious finding. It's been seen in both cases, so I've outlined, it's outlined with a white border. As you'll see, the rest of the calcifications are outlined either in white, if they can be commonly found in benign and malignant lesions, in green, if they're more likely to be benign, and red, if they're always thought to be worrisome. So insufficient data for the eggshell calcification, but that's the first type of calcification. Then we have coarse calcification. So large hyperechoic foci within a nodule, as seen here, characterized by post-lesion acoustic shadowing. This can be found in benign follicular adenomas, as well as papillary carcinomas, as well as sometimes they're thought to be characteristic of medullary cancer. So bordered in white, coarse calcification can be found can be found in hash glands. So it can be found in both a benign as well as a malignant setting. Then we have punctate calcifications. And there are two types of punctate calcifications. You can have punctate calcifications with a comet tail artifact versus punctate calcifications without this comet tail artifact. When you have these punctate calcifications with a comet tail artifact, it's thought to be a benign finding. It's thought to be due to it's usually seen in more cystic or complex cystic lesions and thought to be due to thyroglobulin concentrations that are within the nodule. The comet tail artifact may be visible at the higher frequency of scanning, but sometimes you need to drop to a lower frequency of scanning to see the comet tail artifact. And these are highlighted in green because they're a universally benign finding. as opposed to your punctate calcifications without the common tail artifact, which are worrisome, are more frequently associated with malignancy and nodules that contain these punctate calcifications without a common tail artifact should be biopsied. So, having said that, let's first look at some benign appearing nodules. So, an isoechoic to hyperechoic nodule with a nice halo, smooth margins, and peripheral vascularity. So, isoechoic, nice halo, smooth borders, peripheral calcification, vascularity, excuse me. Similarly, what we call spongy lesions. These spongiform or spongy lesions, sometimes they can be difficult to distinguish from a solid lesion with multiple cysts, but oftentimes you'll see this characteristic sponge-like appearance, and these nodules tend to be, this is a benign characteristic, and these nodules tend to be benign, especially when they're also characterized by peripheral vascularity. Now moving on to sonographically suspicious nodules. So these would be lesions that are hypoechoic, that have irregular margins, that have punctate microcalcifications, and intranodular flow. So first, I hope you can easily see a nodule with a lobulated, invasive-looking border. Similarly here, a nodule that appears to be invading into the surrounding tissue with a lobulated border. Taking that one step further, a nodule that's with a lobulated border, irregular border, that now also has these punctate calcifications. Same thing here, punctate calcifications, a nodule that's hypoechoic with irregular borders. Similarly, a hypoechoic, possibly cystic lesion with a component of solid tissue that's highly vascular, and a nodule that's characterized by significant intranodular vascular flow. So now, having said all that, 2/3 of benign nodules have at least one positive ultrasound predictor of those that we've discussed for thyroid cancer. And similarly, about 2/3 of papillary cancers have at least one non-suspicious ultrasound feature of those that I've mentioned. So the way that sums up is that while we wind up having a high specificity or a tolerable specificity for most of these findings that we discussed on ultrasound, the sensitivity winds up being quite low and not appropriate for a screening test, which is what we're trying to do here, is use the ultrasound as a screening test to screen thyroid nodules for benign versus malignant characteristics and take the next step. So, and of course, for a diagnostic test, as I mentioned, you need to have high sensitivity. And so that's why ultimately we still need to rely on FNA, which has a very high sensitivity and high specificity. And the way thyroid ultrasonography and the characteristics of these nodules, as I've mentioned, are currently used is to risk stratify nodules and make a decision on where they lie along this pathway and make a decision on the indication, weak versus strong, to proceed with an FNA biopsy. So purely cystic, spongiform, as I mentioned, mixed cystic versus solid, and then as you go higher, solid and hypoechoic, microcalcifications with irregular margins, and then, as Steph will talk about, the presence of lymph nodes, extracapsular invasion, and the one thing that's not on here is the vascular flow. And essentially this is how thyroid ultrasonography should be used by all of you in your clinics as an adjunct tool to help decide which nodules look more suspicious and are more likely to yield a positive result in a multinodular gland, and also which nodules that may even be smaller than a centimeter you may want to decide to biopsy in a particular patient, either because of the ultrasound findings, as we've discussed, that are suspicious, or a combination of their personal history, family history, radiation exposure, etc. So that's all I had for you this morning, and Steph will follow up with the advanced section. Thank you very much. Should we hold questions till later?
Yeah.
Okay.
So that was sort of the basics, what you look for a thyroid, what you look for in a nodule. And I'm just going to move on and talk a little bit about now, once we see a nodule, once we think it's suspicious, how to perform an FNA, talk a little bit also about the identification of abnormal lymph nodes in patients with thyroid cancer, and at the end just touch a little bit on other uses for ultrasound, specifically identifying parathyroid adenomas in patients with hyperparathyroidism using ultrasound. I see people fanning themselves. Is it really hot in here? In general, yes. Andrew, could you just go out and see if they had said it was hot, and I was so freezing when I started this that I was like, there's no way it's going to be too hot in here. But even I can feel that we'll try to put a little air on. Okay, so I've already gone through this. Okay, so I'm going to just start with a little bit on fine needle aspiration. So this is just the chart from the 2009 ATA guidelines on the management of thyroid nodules and thyroid cancer. So the key here is that when you're making a decision of which nodule to biopsy, it's not just you have a nodule, you're going to do a biopsy. There's things to think about. Just as Andrew pointed out, nodules that on ultrasound appear suspicious versus those nodules which, based on their sonographic appearance, really appear very much like a very typical benign nodule. So we use, in the guidelines, what they've put together is this chart which combines, 1, the sonographic features, 2, the size of the nodule, and then 3, issues of high-risk history. So things that are high-risk history are people who were exposed to radiation as a child, people with strong family histories of thyroid cancer. So people, when you have a patient who does have certain background risk factors, you may consider a biopsy of a nodule that might be smaller than someone who doesn't otherwise have those risk factors. So if we just look at this, you'll see high risk features as well as suspicious sonographic findings, microcalcifications, hypervascularity, even a teeny tiny nodule, 5 to 9 millimeters, you might want to consider doing a biopsy. I would not standardly do a biopsy on a small nodule like that, but really when it looks very suspicious or the patient has a really concerning history, it's certainly something to consider. And even if they have a high-risk history, without a lot of sonographic findings, you may want to consider a biopsy, but it's not that recommendation is actually an I, which means it's not necessarily recommended. It really needs to have sonographic features. If you find cervical lymph nodes, abnormal cervical lymph nodes, and I'm going to show you what that looks like. So if you do an ultrasound and you see a small nodule that may look a little bit suspicious, but it's fairly small, and you look at the side of the neck and you see an abnormal lymph node, you certainly should do a biopsy either of the lymph node or of the nodule. So identifying an abnormal lymph node is one of those higher risk factor things that would prompt the biopsy. But other than that, if you just have a nodule, you don't see any abnormal lymph nodes, you have no other history, if you have a nodule that does have microcalcifications, or it's a very solid hypoechoic nodule, that's something you would consider a biopsy as long as it was over a centimeter, not if it was smaller than that. As we move on, if it's solid and either iso or hyperechoic, little less suspicious, because as we said, the hypoechoic is the more suspicious finding. We would only do a biopsy of a solid iso or hyperechoic nodule. It would need to be a little bit bigger, now getting more towards 1.5 centimeters. And then if you have these mixed cystic and solid lesions, things like that, you're starting to say, again, larger nodules, greater than 1.5 to 2 centimeters. And if it looks predominantly cystic or that spongiform appearance, you would only biopsy those nodules if they were very large, greater than 2 centimeters. So we just are trying to make this decision for biopsy, kind of combining everything that we know, history, size, ultrasound features, to try to have a more more a practical and thoughtful approach to biopsy. If something is a purely cystic lesion, no solid component at all, FNA is not recommended for pure cysts within the thyroid. So every nodule that you have in your thyroid does not need to be biopsied with ultrasound guidance. We generally do most of our biopsies today with ultrasound guidance, but it's not an absolute thing that has to be done. There is still a role for biopsies with palpation. But there are certain nodules which absolutely should never be biopsied by palpation because you have a higher chance of not getting a good result or a false result. So if the nodule's very difficult to palpate, it's really hard to biopsy it by palpation, obviously. So things that are very posterior and things like that, nodules that are seen on ultrasound and not clearly palpable, would really require ultrasound for that biopsy. Nodules that are predominantly cystic but may have some solid component, you really need the ultrasound to guide you in doing a biopsy. If you just stick the needle in by palpation, you're more likely to just be in the fluid component and not necessarily going to be in the solid component. If you have a nodule that was biopsied in the past by palpation and it was non-diagnostic, generally we do recommend a repeat biopsy be done with ultrasound guidance. And lastly, if you have a nodule that was biopsied previously and was benign, but as you followed it with ultrasound, it's growing, it raises this question that maybe that initial biopsy wasn't accurate and the repeat biopsy should be done with ultrasound guidance so that you have more accuracy and know that the needle was truly in the nodule. And these are just some examples of nodules that would really be more difficult to biopsy with palpation. This is a posterior nodule. You can see it does raise the upper border of the thyroid, and you likely would palpate that there was an abnormality on this right side of the thyroid. But the nodule itself is actually quite posterior. And if you just biopsy by palpation, generally you're biopsying more superficially with that technique. And your likely is that your needle is going to be in that superficial normal tissue and not make it all the way down to the nodule. And so by knowing where that nodule is on ultrasound gives you a better sense that this is a nodule that would be better biopsied with ultrasound guidance. Here the second nodule is again a posterior nodule with more irregular borders. Again, very different. This one's not even palpable, so certainly not one that could be biopsied without ultrasound guidance. And here's an example of one of those nodules that's predominantly cystic, but there is some solid component in two different areas. When you put on the Doppler, you can see that it's this area over here that's truly vascular, and that would be the area that really needed to be targeted during a biopsy. And again, you'd need the ultrasound to really target that area and know that your needle was there and not, even though this nodule very well may be a palpable nodule. And this is just some data to say why we do this. And basically, in these two studies that are now relatively old, they looked at the false negative rate when that biopsies were done by palpation. It's quite low, somewhere between 0.5 and 2.3%. So it's low, but it's not zero. And when they then used ultrasound guidance, you can see that the false negative rate does drop significantly. And really what they found is that the reason for these false negative results were really due to sampling error. It was times when they were biopsying cystic lesions and not in the solid component, or times when the actual nodule itself wasn't biopsied because of its location. So when we do a biopsy with ultrasound, there's really two ways to do it. You can do it all by yourself. You hold the ultrasound probe in one hand, you hold the needle in the other hand, and do the biopsy on your own. The other option is approach using two people, where one person actually holds the probe in place and one person does the biopsy and has the needle. It can help, especially as you're learning, to have the two-person approach, because getting the coordination of holding both the probe and the needle can be quite difficult. So when you do a biopsy, you don't need any special tools. You don't need echogenic needles or anything like that. A 1.5-inch needle, gauge between 23 and 27 gauge, is perfectly fine, and that's all you need. You can attach that needle to a normal 10 cc Luralox syringe. You can also, some people biopsy with just the needle alone, not attached to anything. I generally use a syringe because it gives you something to hold on to. We generally will break the seal, put a little bit of air into the syringe, and then in general, depending on your technique, you need to use a cover of the probe and sterile gel if your needle is going to be really close to the probe. If you're able to do the biopsy such that your needle's a little bit further from the probe and not going to come in contact with the gel, it's not necessary. So it really depends on what you're doing. The issue is if you go through gel with your needle as you're doing the biopsy, that gel is going to hamper the sample and make it very difficult for the cytologist to interpret it. The gel messes up the cells. You just need to clean the skin with some alcohol. You don't need to use a lot of betadine or anything like that. A little alcohol is perfectly fine. And you don't need any special guides. A freehand technique is just fine. You can just move the needle up and down within the nodule and then prep the sample, which Dr. Massoll will go over. So these are just the two most common techniques that are used for ultrasound-guided biopsy using a linear ultrasound probe. So here the probe is on the patient's neck. This is called the parallel technique, when the needle goes in just parallel to the plane of the probe. The perpendicular technique, here's your linear probe. Your needle's going to go in right at the middle, just perpendicular to the probe. And when you do these different techniques, you're going to see different things. So here again, the linear probe, here's your nodule. You bring your needle in just on the side of the probe, parallel to the sound waves going down, and you're going to then see the needle in the nodule. With that perpendicular technique, the probe's here, here's your nodule. Your needle's coming in right in the middle of the probe. All you're going to see in the nodule is a bright dot. Here's a bright dot. It takes a little bit of practice to get a sense of whether that bright dot is the tip of the needle or the middle of the needle, and that can be a little bit hard. It's a little bit easier, though, to get into the nodule with the perpendicular technique. And hopefully we'll have time in the practicum for you guys to try these different techniques, like I said, with the turkey breasts. So typically, most commonly, these biopsies are done with a linear probe like this. The probe's there right over the nodule. The needle comes in right next to the probe. There are also curvilinear probes, which can be used for a biopsy. And with a curvilinear probe, your probe actually comes to the side of the nodule. Your needle comes in straight up and down. You're a little further from the probe, and you have a little bit of a wider plane, so it's a little easier to keep your needle in your plane throughout the process. So here's an example of an FNA with a curvilinear probe. You can see the nodule here. The probe is on the side of the nodule, and then you can see the needle within the probe throughout. But it does rotate. There's a little bit of a rotate, so even though your needle's coming in right from the skin, on your screen it comes in from the side of the screen, and it takes a little bit getting used to. So that's just a bit about biopsy, which nodules to biopsy, and how to do it. I'm going to move on and just talk a little bit about the evaluation of lymph nodes. And the reason that we think so much about lymph nodes in patients with thyroid cancer is that about 42% of patients with thyroid cancer present with lymph node metastasis at the time of diagnosis. So it's really something that's not uncommon. At the time of diagnosis, 21% of these lymph nodes are macroscopic, meaning larger than a centimeter. And if you look at a large database, SEER database, about 22% of patients with papillary thyroid cancer will have lymph node metastasis at the time of diagnosis. This is probably a little bit of a more accurate number. That 40% is an older study and maybe not quite as accurate. But based on this finding, these are just what the guidelines have been put out as our recommendation. And the key here is that a preoperative neck ultrasound, when you have a patient who has thyroid cancer, had a biopsy, has thyroid cancer, is going to go to surgery, you really want to make sure you go back and do an ultrasound, look at the other lobe of the thyroid, look at all of the lymph nodes, and evaluate them before surgery, because lymph node metastases are not uncommon. If you see them prior to surgery, it really can help guide the surgeon and make sure the most complete surgery has been done, including a lymph node dissection. So on ultrasound, when we look at lymph nodes, a normal lymph node is going to be oval in shape. It's going to have a bright echogenic hilus, which is this little fatty tissue right in the middle of the lymph node that's going to look bright on the ultrasound. And the vascularity in the lymph node is going to be right within that fatty hilus. So here's an example of a normal lymph node. You can see it's oval. You can see this bright stripe right in the middle, which is that fatty hilus. And here's another example. The vascularity is not great, but you can see this lymph node here, that white stripe, and there is just a little bit of vascularity right within that hilar region and not anywhere else. Oh, this didn't come out very well, but this is just an example. The way the lymph nodes in the neck are broken down is into compartments. And so level 6, which is here, is the central compartment. Those are the lymph nodes right behind the thyroid gland in the middle part of the neck. And as we move into the lateral neck, we have levels 2, 3, and 4 in the side of the neck, and then posterior to the sternocleidomastoid, level 5 back there. And so these are the areas where you can get lymph node metastasis from thyroid cancer and the areas that are generally evaluated. The submandibular lymph nodes at level 1, very uncommon site for thyroid cancer to spread to that area. So now what do we look for when a lymph node is abnormal? Instead of that oval oblong shape, the lymph node becomes much rounder. In addition, the echogenicity, a normal lymph node is generally hypoechoic, whereas a lymph node specifically with papillary thyroid cancer, which is the type of cancer which most commonly spreads to lymph nodes, that lymph node will more likely be more hyperechoic or a little bit brighter. The hilus disappears, so there's an absence of that hilus. You lose that bright stripe. You can see cystic change within the lymph nodes, calcifications, and generally an increased vascularity, particularly in the periphery, and as well can be in the central area, as opposed to that little spot of vascularity right in that central hilum that we've lost. So here's an example. This is first just an abnormal nodule with irregular borders, microcalcifications, and then as we look in the lateral neck, this is an abnormal lymph node. You can see that this lymph node is round. It's round. It is somewhat hyperechoic, or more about the same as the strap muscles, and you've lost that fatty hilus. Here's another example, again, an abnormal nodule with microcalcifications, infiltrative borders, and as you look more carefully, you can see this abnormal lymph node here. It's very round. It lacks your fatty hilus. It does contain some pinpoint microcalcifications, and when we look at the vascular pattern on this lymph node, it has a peripheral vascular pattern. This is a very suspicious appearing lymph node and would warrant evaluation. And so from there, just again, if we look at what the guidelines recommend, they say that if you see an abnormal lymph node and diagnosing that would change your management. It is something that should be biopsied. You can send it for cytology. You can also wash out the fluid that you do when you biopsy a lymph node. You can wash it out and send it for thyroglobulin. Sometimes when you have a small lymph node, you may not be able to get tissue for cytology, but if you wash it out with a little saline and send it to the lab for thyroglobulin, you may see elevated thyroglobulin levels despite the fact that the cytology does not show a lot of cells. And that can be done even in a patient who has positive thyroglobulin antibodies. You can still measure the thyroglobulin in a lymph node washout. And just to conclude then, I'm just going to touch briefly on the idea of using ultrasound not just for the thyroid nodules and lymph nodes, but also when you have patients with hyperparathyroidism. So this is just a summary of the consensus guidelines that there have been now 3 NIH consensus conferences on recommendations for surgery in patients with primary hyperparathyroidism. So primary hyperparathyroidism is a really common disorder. You will see it all the time if you haven't already. The question is, who needs surgery for this? Most people are completely asymptomatic and really don't have a lot of problems related to the hyperparathyroidism. So we're looking for reasons to do surgery. And in general, the current recommendations are very high serum calciums, 1 above the upper limits of normal, reduced creatinine clearance, osteoporosis, and a young age. Any of those factors in the setting of clear hyperparathyroidism is a reason to consider surgery. It used to be that they also thought very high urine calcium was an indication for surgery, and that's actually been eliminated from the recommendations. And the idea is, though, if you have someone who meets these criteria, you're going to recommend parathyroid surgery. One of the keys, as these guidelines point out, is that, or this conference points out, is really you want an experienced surgeon. Parathyroid surgery is really best in the hands of someone who does it a lot. And the idea nowadays is that people really want to move towards the minimally invasive parathyroid surgery. Instead of the traditional surgery where you would explore all 4 glands, identify the abnormal gland, and remove that gland, this approach, you just go into one side of the neck and you remove the abnormal gland, monitor the parathyroid hormone level intraoperatively to confirm that you've removed all of the abnormal gland. And the nice thing about this surgery is that it's a shorter surgery, the incision is smaller, and there are fewer complications, most specifically postoperative hypocalcemia. With that traditional surgery, when you had to explore all 4 glands, it was quite common to at least have transient hypocalcemia after the surgery. If you only go in on one side, much less likely. The issue with this surgery is that you have to identify the abnormal gland preoperatively. And the other issue is that there are cases where patients have double adenomas, and that can be missed when you use this minimally invasive approach. And so the idea of utilizing ultrasound is a way to help the surgeon guide them and identify the abnormal parathyroid gland. In general, you can look for normal parathyroid glands when you do your ultrasound, but you're probably not going to find them. They're very small, very difficult to see a normal gland. But when someone does have an abnormal parathyroid gland, it becomes more clear. So here, just posterior to the posterior aspect of the thyroid in transverse view is this hypoechoic, very smooth oval lesion, very classic appearance of a parathyroid adenoma. And here's that same lesion on the sagittal or longitudinal view, and you can see hypoechoic, very smooth, regular borders. And the key with identifying parathyroid adenomas is really pattern recognition. They're looking at the appearance, that hypoechoic oval lesion, looking at the location. On that transverse view, you're going to see the parathyroid just posterior to the thyroid gland itself. And here's an ultrasound showing that same thing, that lesion there. And on the longitudinal view, you can get even more information regarding whether this is a superior or an inferior parathyroid gland. Very difficult to determine that on the transverse view. But on the sagittal view, the inferior parathyroids will be just below the inferior margin of the thyroid gland, where the superior parathyroids will be in the midline of the thyroid gland on longitudinal view. And here again, as a real ultrasound, you can see this oval hypoechoic lesion, inferior pole of the thyroid, superior pole of the thyroid. This is right at that midpoint, so most consistent with a superior parathyroid adenoma. And on the other hand, here's our inferior pole, superior pole over here. This lesion really more off the edge of that inferior pole, more likely to be an inferior parathyroid adenoma. And there's also a very classic vascular pattern for these parathyroid adenomas. It's called a polar vascularity, more of a feeding vessel. So you'll see one vessel coming into the lesion there, as opposed to that hilar vascularity of a lymph node where it was right in the center. And here's another example of a feeding vessel coming into or polar vascularity within that parathyroid lesion. So just to summarize, the keys when you're looking for parathyroid adenomas, the appearance, oval, homogeneous, hypoechoic, the classic location, and the polar vascularity. And then just experience by just doing this and looking and trying to see them in the patients that you do see with hyperparathyroidism, you'll start to recognize what they look like. So with that, I know it was a lot of information in a short time, but we wanted to just kind of expose you to all of these different aspects of ultrasound. And I'm going to step aside and I'm going to invite up Dr. Massoll, who is a cytopathologist, and she's going to come and talk a little bit about cytopathology from fine needle aspiration. And when we go over to the practicum, she's going to have a station where you're going to have a chance to prepare slides using liver, look at them under the microscope, and help you to learn about adequacy.
So you guys have now gone over which nodules you're going to biopsy, You've gone over what all the features are. You know how to do the FNA. Now the question is, you've done the FNA. What do you do with the sample? And how do you know what you got, right? So, with that, we're going to look at just a few of those kinds of things. So to do this, you're going to see everything when we go next door, but you have to have your glass slides. And remember, these glass slides are going to get dipped in alcohol for staining purposes. So anything that's a marker or a pen is going to wash off when you label it. So label your slides with pencil, okay? You're going to look at, we'll talk about doing pap-fixed slides, which are the alcohol-fixed ones, and we're going to talk about doing air-dried slides, which are the ones that are done with the diff quick or the rapid stain. That's the stain that we're actually going to practice next door, because the diff quick only takes about a minute and a half to do. Your pap stain, while there are ultra-fast pap stains out there, most places do not use them. So that stain takes about a good hour and a half, so it's not something that you'll typically participate in. Most places will use some sort of a rinse. Right now, many of them are alcohol or formalin-based. Many places are switching over to more of a molecular-friendly fluid for your rinse, so that as we progress through this era or dilemma of molecular, we can decide which nodules we want to reflex or send testing off for. And then your requisition form. We're trying to train cytopathologists with the same lingo that you're learning and using for ultrasound, okay? So the more information you can give them that the nodule is hypoechoic or hypervascular or circumscribed or irregular margins, the more specifically they can help you with what your diagnosis is, okay? In the new Bethesda terminology, there is the option that your cytopathologist can tell you if you give them all cis fluid. Instead of calling it unsatisfactory, they can tell you that it's consistent with a cyst, but you have to give them that history, that by ultrasound it's consistent with that, or you're not going to get that. You're going to get unsatisfactory, because they cannot tell you that without knowing that's what you are already thinking, so that the two go together, okay? So the requisition form is actually very important. All right, so this may be what your setup would look like. In my clinic, this is how things look, and I have a container off to the side here, which is for my air-dried slides that I stain while I'm in clinic. The green top tube then has alcohol in it, and that's what I put the slides in immediately for the pap stain. This is going to be an alcohol. You're going to see these stains next door. This is going to be fast orange or orange G, and this is going to be hematoxylin. Some sort of a tube for a rinse, and then my slides that I label with the patient's name. All right, so there's lots of different ways that you can prepare the sample once it comes out of the patient. The gold standard is to make smears, all right? And smears can be exactly that. They can be where you take the sample and you smear it out. The gold standard truly means glass slides that you make at the time that you're doing the procedure. We're going to show you another real quick method right across the hall, and I'll go through it briefly here. It's called a book method or a pop-apart method. So when you're over there, we can practice making slides if you haven't done that with smear methods, or this pop-apart method. Cytospins are what we make from that rinse media. Typically, they're just a cytocentrifuge concentrated sample, and it gets a pap stain on it. And then a cell block. And cell blocks are very rarely used for thyroid FNA. If you tell us they have a history of malignancy and you're worried about metastatic disease or something like that, we may want to do a cell block looking so that we can stain it for other things. It takes a little bit larger sample to make a cell block from. We can actually do cytocentrifuged or cytospin samples and do immunohistochemistry off those, which requires not as much cellularity. So don't think that even if you don't get a lot of cells that you can't get stains. You can still ask. All right, the way the slides can be done that we're going to talk about is air-dried slides. That's your first type. And alcohol-fixed slides. That's your second type. The air-dried slides are the ones you're going to use today, and those are the ones that go through the diff quick or rapid staining, okay? It's a modified Wright-Giemsa, Romanowski type stain like you would use for peripheral blood smears, and that's what we'll stain things with today. If you have looked at reports that come back and say air drying artifact or something like that on the report, That's the ones that go this second one, the alcohol-fixed slides. If they don't get into the alcohol immediately, the edges of the smears start to air dry, and that's when you're getting the comment of air dry artifact. The first kind that we stain in clinic and do the difficult kind, those you want air dried. You're never going to get a comment like that. That's the whole purpose of those. So these air dried ones allow us to look at things immediately, because we can use the stain in clinic. It does change the cells a little bit in that they look a little bit bigger. So if you're used to looking at them in a pap stain with your pathologist, don't be surprised when the cells look slightly larger on the DiffQuick. The alcohol-fixed slides, though, provide the opportunity to do the Papa Nicolau stain, and those are much better for nuclear detail. We're going to go over that in just a second. So the DiffQuick stain, while we can use it in clinic, the other benefit of it is that it lets us see and appreciate colloid a whole lot better than a pap stain does. So in thyroid FNA, the really good thing about the DiffQuick is that it allows you to look at something rapidly, it allows you to look at something while the patient's there with you, and you can determine adequacy, and it gives you a better appreciation of colloid. The pap stain, on the other hand, you need to put into the alcohol right away. It's something that's going to come out either later that day or the next day. And the thing that we really like about it is that all those grooves and inclusions that you hear us talk about for papillary thyroid cancer, that's where we can see them the best. So pap stains really help us confirm those great nuclear details that we all look forward to seeing for papillary thyroid cancers. Now, hematoxylin and eosin, or the H&E, is the classic surgical pathology stain. So when the thyroid comes out and we cut it up and we do sections with it, you get an H&E slide. If you do a cell block, you'll also get H&E slides, okay? So that's when that stain's used. It's not a regular cytologic stain at all. This may be what your setup would look like. Your first container there is clear, and that's the alcohol. That's what you're going to fix the slide in once it's dry. The second container, depending on the brand you buy, is either called Orange G or Fast Orange. And then the last container on the end is really a dark blue or dark purple, and that's your hematoxylin. All right, so I'm going to run through just briefly how to do this other methodology, which is called the book or the pop-apart method. And to do that, when you do your FNA, you take your sample and you put a small drop into the middle of the slide now instead of closer to the end where you would normally put it to do classic smears. You're going to take the slides and you put them like a sandwich on top of each other, okay? Once those two slides are on top of each other, you're going to let that sample, just by capillary action, spread out as far as it'll spread, just to make it as thin as possible. And you can sort of see the outline of the sample here. Now it's spread all the way, kind of like this. So now it's spread as far as it's going to spread, and it's called the book method because you can either open it just like this or you can just pop them open, so it gets the name pop-apart or book method. And it gives you two slides now that are mirror images from that same FNA. So one can go immediately in alcohol for your pap stain, and one can be air dried and you stain while you're there with the patient, and you can determine adequacy from it. The pathologist will look at that one as well, look at those cells, they'll be able to see colloid, they'll be able to say, if there's something funny on this DiffQuick, they can go to the pap stain and confirm it on the pap stain and see all the lovely nuclear detail. So it's a very nice sample for us. When we do DiffQuick staining, you want to make sure that the slide is entirely dry, okay? So when you're over there, I'm going to show you a couple of them. When you put the sample on the slide, it looks like wet paint, okay? It's real shiny. Once the sample's dry, it has that dull, flat paint kind of look to it. It's no longer shiny at all. Once it's dry, you're going to stick it into the 95% alcohol for approximately 30 dips or 30 seconds. You're going to transfer it to the orange container for about 30 dips or 30 seconds, and then into the blue container for about the same. The last container you're going to see on the table is just going to be water. That only takes 4 or 5 dips just to rinse off the extra stain. You will have taken that glass slide and put your initial on the front of it. Make sure that initial is facing you. Pick up a piece of gauze and wipe off the extra water off the back, otherwise it sticks to the microscope. Now I'm going to tell you this one more time. Make sure your initial is facing you and you wipe the back off, because someone's going to wipe their sample off the slide, okay? It happens all the time. Trust me. All right. The whole reason for doing this is so that we can look for adequacy while the patient's there. You've done the FNA, you know what you want to biopsy, you've gotten a sample out. Now really you want to find out, do you have enough cellularity that you're actually done, or do you need to stick the patient again? So the DiffQuick allows you to see cellularity. It lets you look at different cell types. It lets you look at colloid. You can see architectural fragments. So it provides a lot of opportunity and a lot of information. The next problem, though, is what's the definition of adequacy? There's been several definitions of adequacy over the last several years that have been floating around out there, and I just want to give you a little of the history behind it to how we got to where we are today. So it started out saying, okay, well, maybe 5 or 6 groups of cells was enough. If they have 10 to 15 cells in them, okay, then we have enough cells there. Then we got to, well, we really need more than 8 cell groups, and it should have at least 10 cells in these clusters. And then our governing body, which is the Papa-Nicolau Society, came up with sort of trying to summarize the different definitions out there. And this first definition is actually the one that I used, which is the 6 to 8 groups of well-preserved follicular cells with 10 or more cells per group. So that's what we're going to discuss next door. There is an additional published definition out there, which is the 6 groups of follicular cells. But now it needs to be on at least 2 slides from separate passes. So at this point, I think we need to diverge just a minute and say that adequacy really is somewhere around, if you take all of these different numbers, say 100 cells, right? You can typically get that in a pass, maybe 2 passes. And if you have a small nodule, that may be enough to sample the nodule, right? Because you've put the needle in different places. If you have a 5-centimeter nodule and you've only sampled this part and this part, you may not feel that you've adequately sampled the nodule. So adequacy really depends on have you adequately sampled the nodule, in which case you should target those areas that they just discussed with you and go, find those suspicious areas within the nodule so that you can feel comfortable with sampling the nodule, and then your adequacy that you get is really representative of your most suspicious features within that nodule. So what do we look for? You're going to look at some of this across the hall. Follicular cells typically have nice round nuclei. In benign nodules, they really don't overlap a whole lot. The cytoplasm is nice and thin and lacy, and they're very respectful of each other. This cluster, on the other hand, they overlap, they're elongated, they're not round anymore. This was a follicular variant of papillary. So the thing that we're looking at this is clusters. See how the cells all stick together? Because in a minute we're going to discuss the things that don't stick together that you see on the slides. So the important part about adequacy is finding clusters of cells, because remember, follicular cells and Hurthle cells are what make up the malignancies, right? So when we have other cells in there, if you have Hashimoto's thyroiditis, you can have macrophages, you can have lymphocytes, but those don't make up the malignant parts of the lesion, right? So you don't use those when you count cellularity. So the only cells that count are clusters of cells that are follicular or Hurthle in nature. So here's another example of what follicular cells can look like. I'm sure you've heard of the microfollicular patterns that can be seen. So here's a nice microfollicle in the center with some inspissated colloid. And this is Hurthle cells. So Hurthle cells are much larger cells, have much more abundant cytoplasm. Instead of the nucleus being in the center of the cytoplasm, now you see the nucleus sort of sits off to the side. Here you can see the nucleus, while it's round, sits over to one side. The cytoplasm occupies the other side of the space. And the cytoplasm is a little bit more granular, which we'll look at here. So here we can see again the nice round nucleus. We can see the abundant cytoplasm. And we can also tell that there's little specks in the cytoplasm. So this is a cluster of Hurthle cells. Now, we always like to see colloid because that makes us feel better, too, that we're not discussing follicular lesions. So colloid can look in many different ways. See the little folded areas within? This is called the pattern of draped silk colloid. So if you're familiar with fabric and you take it and drop it on the floor, it gets all ripply. This is called the draped silk pattern. If you look at this cluster over here, this has got some thinner colloid in back, and this is called fluffy colloid. So we like to give it lots of names. Now, the cells that will confuse you for those Hurthle cells are these macrophages. But what did I tell you? These are going to have round nuclei, they're going to have speckly things in the cytoplasm, but there's typically a lot more cytoplasm. The speckly things are many different sizes. There'll be big speckles, little speckles, there'll be clear vacuoles, and they're not going to be tightly stuck together. They're going to be single cells here and there, or a couple clustered like this, but they're not going to make big clusters of cells. So if you stick to looking for the purple clusters, you'll stick to looking at the epithelial components. Now, there used to be some discussion, and fortunately most of you haven't had to deal with this, of having a CLIA license to do adequacy in your office. As of January 1st this past year, CMS took that away. You do not have to have a CLIA license to perform this in your office anymore. And there have been some updates in coding. When you do your initial biopsy adequacy determination, you use the code 88172. And then for each additional pass that you do to determine adequacy, you use the 88177. Now, when you dictate, just like you do for your ultrasound, what you saw, the size of the nodule, calcifications, hypoechoic, vascular, all that, it's just as important when you dictate your note for your procedure that you say on pass 1, there are scant follicular cells and macrophages and colloid. Pass 2 had lymphocytes only. Pass 3 had adequate cellularity for Hurthle cells. So you have to document what you saw in each of the passes to give justification for why you did each sequential pass, okay? So as you get into this and you start to do more and more looking at slides and staining and things like that, just remember that just like you do for your ultrasounds and your procedure notes currently, you have to have justification for why you do each additional pass if you want to get paid for them. That's all I have from this, and we can go through any more of this when we get across the hall. Are we doing questions now or over there? Okay.